So good afternoon and welcome to all to today's, QASA's virtual poster walkthrough for physical therapists and clinical evaluators. My name is Mary Curry and I serve as the Director of Clinical Affairs at QASA, a nonprofit organization that is committed to changing the lives of people with spinal muscular atrophy. For those that are unfamiliar, QASA is the largest network of families, clinicians, and research scientists working together to support affected individuals and families while also educating the public and professional communities about SMA and advancing pivotal research. As part of those research efforts, QASA established the SMA industry collaboration in 2016. We recognize that no single group can research and develop a treatment for SMA alone. So the collaboration provides an opportunity for us to work hand in hand with providers, researchers, industry, and families to collectively develop projects benefiting the community. Through the industry collaboration, we fund research to ensure that treatments on the robust pipeline address the unmet needs of the SMA community. Oops, excuse me, just a little reverb there. If we could all please mute, that would be fantastic. Thank you. So the collaboration itself consists of 4 topic groups which cover an array of subjects. The regulatory topic group engages the FDA and other regulatory agencies to bring the patient voice to the SMA drug development process, and also is working very closely with the Pediatric Neuromuscular Clinical Research Network, or PNCR, to develop and refine outcome measures. The education topic group engages parents and providers to promote awareness of the early signs of SMA, to reduce diagnostic delays until universal newborn screening can be achieved. The patient-reported data topic group is working to better understand and document the changing SMA phenotype. And lastly, but certainly not least, the clinical trials topic group, who has also developed today's session, is working to increase trial site capacity and readiness across the United States and Europe. So for additional information regarding the goals of the collaboration, I encourage you to visit QASA's website, but to further describe initiatives launched by the clinical trials topic group, I would like to introduce the topic group lead, Ilsa Peterson. Ilsa, I will hand it over to you.
Great, thank you so much for that introduction, Mary, and I'm so glad to see so many people here today, some faces that are familiar to me and some new faces. I'm Ilsa Peterson. As Mary mentioned, I am the lead for the QASA Industry Collaboration Clinical Trials Topic Group, and I've been working with the industry collaboration since it was first formed 6 years ago, which is kind of incredible how time flies. We've had the Clinical Trials Topic Group as a part of the industry collaboration since its inception. And through this group, we provide an array of resources to support effective patient-centered management of SMA clinical research and patient evaluation. You are going to hear a little bit more about some of our PT-focused materials and resources from Sally and Kristen in just a moment. But suffice to say that we really try to make this and the resources that we provide a dynamic program. It's one where we try to be thoughtful about the current needs of the community. We try to listen, I think, to what needs are, to what we're hearing in conversation with all stakeholders. And that is inclusive of certainly sponsors who are part of the industry collaboration, but also, of course, collaborators across the patient community, across the clinician community. And the resources that we've created, we believe, are reflective of input from all those different sources. So I'll make one short plug for our Clinical Trial Readiness Hub before I turn things over to Sally and Kristen to speak more about our PT-centered activities and resources. Our Readiness Hub, and I will drop the link in the chat for everyone. We opted, I'll say, we opted to avoid slides for the introduction here, just because you'll see slides throughout the course of our meeting, and we just wanted to make this a little bit more discussion oriented at the outset. But our Clinical Trial Readiness Hub is our online go-to resource where we have a couple of readiness checklists, which are overview checklists to help clinical research professionals examine preparedness for SMA clinical trials. We have 2 of these available, one that focuses on trial sites as a whole, and a second that focuses on clinical evaluators. We have 3 toolkits and a 4th PDF of additional external training resources that have been created over time. One toolkit is on SMA, a second is for clinical research coordinators, a third, which Sally and Kristen will speak to, is for physical therapists. And then through the program, we also run an array of workshops and webinars and make available information about some other complementary programming that QASA has. So very pleased to have everyone here today. I'll say one final note just in terms of housekeeping before turning things over to Sally and Kristen to speak to PT resources and generally introduce the program here. So we circulated to everyone who had registered as of yesterday close of business our agenda for today, and we're just walking through that. So we're covering a couple of introductions now, and then we'll dive right into the content. Everyone should have that agenda in their inboxes, and all of their speakers, I believe, also have that information. If there's any reason that you haven't seen that or you don't have that, please feel free to reach out to me or Mary. We'll be happy to provide that to you. And then just for the purposes of today's conversation, we have a larger group than we had the last time around that we did this, but we do want to make this interactive. So we will have presentations, we'll have plenty of opportunities for conversation. And just from the standpoint of housekeeping, when we get to conversation, I know we all, especially if you've been attending the annual conference, you might be a little bit zoomed out, but we really would invite you to turn your cameras on for conversation, because I think it just makes such a difference to be able to see people, to see that level of interest. I know when I've been a presenter at these meetings, I really appreciate when the attendees have their cameras on, because it helps me to know and understand that people are engaged and present. So that is our last housekeeping note, apart from just a reminder, as all of you have, to mute yourselves, please, if you're not speaking, to help avoid any sort of background noise. So with those notes, I will turn things to Sally and Kristen to provide some additional notes of introduction. We will then jump into our agenda. We'll have all of our speakers share their own slides. We found that worked well before. And then we'll have just a few minutes of wrap up at the end, where we'll tell you about some ongoing programming and offer an invitation to participate in some work that is being led through this program as well, or has been supported by this program. So Sally and Kristen, the floor is yours.
Okay, so I'm going to start. As some of you know, Sally and I have been involved with QASA for a couple of years now as consultants to their clinical trial readiness program. And one of the main goals of that has been to try to develop resources for you as therapists and clinicians as well as researchers. So Mary and Ilse just put some links in the chat, which we think are some good links to some of the products of that and some of the other resources that we think are valuable. So the toolkit has provided, we think, a great resource of sort of how to go about evaluating and assessing patients, where to find different assessments, what are the best assessments to do in different types. And it goes through some background and history on each of the assessments that we've used in SMA, as well as links to resources. And there's a wealth of information at the end of the toolkit, which includes links to continuing education and professional education programs that we think are also valuable resources. In addition, just a plug, we have just completed the final draft of the second version of that toolkit, which will be available on the QASA website shortly. And Sally's going to tell you about one of our educational programs that's come out of this collaboration.
Thanks, Kristen. Yes, I'd like to just also touch base. There is the SMA Teaching Excellence for Physiotherapists and International Network, Step In, and Dr. Jacqueline Montez gave a presentation during the clinical care meeting yesterday, giving an overview of this program. And really the core purpose is to develop expertise and shared educational resources for PTs who provide clinical care or do research for children and adults with SMA. And the goal is to develop a multidimensional infrastructure, which includes an extensive curriculum based on competency-based education, which she spoke about yesterday, resources, and the stepinsma.org is the house of a platform that we hope will foster mentorship and collaboration and research amongst all the clinicians and therapists treating and managing SMA. Please check out that website.
Right. Well, thank you so much, Sally and Kristen, for those introductory remarks. We can go ahead at this point and jump into our session. And just so that everybody does have it handy, I'm going to just share for a moment the agenda. We can walk through the couple of talks to come, and then we'll turn things over. Amy is going to be our first presenter. So just as a quick overview for everyone, this is what we're looking at. I think we're right on time and just a couple minutes ahead actually for session 1. So we'll have 3 different sessions. The first of these focused on assessment with a couple of talks followed by group discussion. The second also being assessment, but part 2 with again a couple of talks and then discussion. And then finally, our last session focused on intervention. So with that, I will stop sharing. And Amy, if you are ready to tee up your slides, please feel free to do that, and we'll turn things over to you to present.
Great, I'm ready, and I've got my slides available, hopefully. Here we go.
All right, we can see them. Thank you.
So hi, everybody. Great to see you all, and I wish, as everyone else, that we were in person, but I'm really looking forward to a year from now, and hopefully sooner when we can all see each other, not over Zoom. So I'm going to introduce a novel concept that we've been talking about as a group in our clinic here at Boston Children's Hospital and go through my presentation. So the title of the presentation is The Development and Implementation of a Functional Mobility Scale for SMA to describe modes of mobility in the home and community settings. SMA types are based on genotype, symptom onset, and achievement of motor milestones, and motor function classifications paint a clearer picture than SMA types, often of current abilities, but represent maximal motor function without assistive devices and at discrete time points. Both SMA types and motor function correlate with gross motor capacity measured with scales like the Hammersmith, but don't describe usual modes of mobility in the home and community. With the introduction of SMA disease-modifying therapies, this has led to more variety in motor abilities and function across SMA types compared to the natural history, especially in type 1 SMA. And the use of historical definitions is still critical. However, a functional mobility scale describing modes of mobility may also serve useful for clinical care. Currently, there are no functional mobility scales that have been validated for SMA. The FMS for CP is a tool that was developed and is used to describe levels of modes of independent mobility across 3 distances, 50, 100, and 500 meters. And it is associated with walk test distances and CP classifications, the GMSCS levels, and has been used to measure discrete changes in function. Use of a scale like the FMS may provide a broader picture of function for people living with SMA and may better inform plans of care. Here's a brief overview of the functional mobility scale for cerebral palsy. It's a 6-point rating scale used to describe how a person with CP accesses their environment. And it describes use or lack of assistive devices, and a total sum score is applied for the person's abilities across each distance. The highest possible score is an 18 and the lowest possible is a 3. Our objectives for this study were 1, to develop and pilot a modified version of the FMS for use in SMA, and we call it the SMA FMS, and 2, to examine relationships between SMA FMS levels in the home and community settings with SMA types and motor capacity measured with the Hammersmith. We had 3 expert clinicians in our clinic with expertise in SMA who reviewed the existing FMS and modified it for SMA. The ordinal FMS scale for CP was expanded from 6 to 9 ability levels, with 1 representing individuals who are pushed by a caregiver passively and 9 representing individuals who walk independently on all surfaces. We replaced the 5, 50, and 500 meter distances with in-home and community settings based on different perspectives we had on SMA and how it was different than cerebral palsy, and also because we rated the participants retrospectively with chart review. We rated the participants based on usual versus best performance, and descriptive statistics were used to describe the distributions and frequencies of SMA FMS scores across SMA types for both settings. We had 126 participants, 33 with type 1, 56 with type 2, and 37 with type 3. And you can see that the mean ages for type 1 were lower than type 2, and which were lower than type 3. Here you can see the scale that we came up with. So there are 9 different ability levels, and you can see the distribution of abilities across our 126 subjects. So the frequencies were calculated for all SMA types and for in-home and community mobility. And the most frequent mode of mobility in the home setting was driving a power wheelchair with a standard joystick. And in the community was being pushed passively by a caregiver. 66% of the participants used the same mode of mobility in both settings, in the home and community. And the most common mode was for those who use the same type of mobility was driving a power wheelchair with a standard joystick, followed by being pushed by a caregiver, followed by walking without a device, and finally driving a power wheelchair with an adaptive joystick. For those whose mobility differed across settings, self-propelling in the home and being pushed by a caregiver in the community was the most frequent combination, and that was 18 out of 44 participants who had differing modes of mobility. Some participants, 17.4%, were completely independent in the home with mobility, but fully dependent in the community. And this included individuals with SMA type 3 who walked independently in their home. The only level that wasn't represented at all by any participants for usual performance was walking with a walker or crutches with CAFOs. We looked at the correlations between SMA type and SMA FMS score, and we found a positive with Spearman correlations, and we found a positive relationship with SMA FMS ratings and SMA types for in-home and community, but it was a moderately positive relationship. We looked at differences in in-home versus community SMA FMS scores across the types of SMA, and overall community ratings were lower than in-home ratings, most notably for those with SMA type 3. We also use Spearman correlations to look at relationships between SMA FS scores and Hammersmith scores in a subset of participants. So there were 86 participants who received the Hammersmith, and we were also able to score their usual performance of mobility based on chart review. And we evaluated the relationship between motor capacity and modes of mobility. The Hammersmith motor capacity and modes of mobility measured with the SMA FMS were strongly related at a correlation of 0.85 for in-home mobility and less so for mobility in the community. Here you can see that we also use Kruskal-Wallis test to demonstrate significant to explore the differences between Hammersmith scores and SMA FMS ratings across each individual rating. And we found that there were significant distances between some of the adjacent ratings, so some of the adjacent abilities, but that our uneven sample sizes across each ability limited further statistical interpretation. But overall, the association of motor function measured with the Hammersmith and level of independence of mobility with this scale was much more strongly correlated for in-home versus community mobility. To conclude, we found that the SMA FMS reveals a variety of modes of mobility in SMA, and that scores were associated with but not directly related to SMA type, showing that the variability of mobility across ages and phenotypes exists in SMA. More than half of our participants had lower SMA FMS scores in the community than the home, highlighting the increased challenges and other variables in the community setting that affect levels of independence and mobility. Some participants were independent with walking or self-propulsion in the home, but were fully dependent on their caregivers in the community, highlighting a potential need for education or a different approach to adaptive equipment prescription for use in the community. The stronger relationship between motor capacity measured with the Hammersmith and in-home mobility compared to motor capacity and community mobility further supports the notion that community mobility is multifactorial and usually more difficult. We think that future analyses with hopefully a larger sample size, if other sites are interested in working on this project together or this concept, would provide more impact on the impact of other variables like fatigue, age, timing of treatment, etc. One limitation of our study is that the data we collected were all from one center, and so adaptive equipment prescription styles may be similar across providers at our site. And we think that implementing the concept of this scale may more broadly will serve as useful. We'd like to thank QASA for their ongoing support for our research. And also we'd like to thank the caregivers and individuals at SMA who participated in all of these studies. And that's it. Thanks, everybody.
All right, thank you so much, Amy. And again, we will have plenty of time for questions. So I hope everybody has been jotting down any questions that they might have throughout the course of this conversation. Really appreciate your presentation. As our second set of presenters, I'm happy now to turn things over to Julie and Megan. I see, Megan, it looks like you're focused on your screen, and the two of you are both ready to go. So I will turn things to you.
Hello, my name is Julie. I'm an occupational therapist at the Johns Hopkins Children's Center. And this is Megan. Nice to see you guys. And today we're going to talk about an emerging upper extremity phenotype in children with spinal muscle atrophy. So as you all know, with all of these little infants now being able to grow into older young children, we started to notice this phenotype, and these infants are all kind of presenting in the same way. And so I wanted to share what we found with how they're presenting and then what kind of interventions we've done. Alrighty, so, oh, did I skip? Sorry guys, I'm like not really great. Okay, so in our little babies, we noticed that they all have this really elevated scapula, the shoulders are up by their ears, elbow flexion, and a lot of pronation and ulnar deviation. All of their MCPs from digits 2 to 5 are hyperextended, and the PIP and the DIPs are usually like fully flexed. The thumb CMC and the MCP are adducted, and then the thumb IPs are hyperextended. So what can we do to address this developing phenotype? Again, just starting with positioning is really important, especially because gravity is kind of pushing against these babies, and it's really hard for them to be in that nice physiological flexion, which is the best position for infants to develop. So like the patient seen in the picture before, if they have a head preference, always turning their head a certain direction, it starts to get flat on that one side. And then it's really hard for them to keep their head in the middle. Because then their head kind of just like falls into that flattening side, and then it's really hard for them to get through that to turn their head to the right. On the right there is a foam pillow that I fabricated using a turkey carver. Pretty much it just offloads the pressure of the back of the head, and helps promote midline positioning. Because again, we really want them, like in the pictures shown here, we want their hands in midline, nicely by their face so that they can explore their hands, get that sensory input. And then again, just trying to have them in that nice physiological flexion, which is really hard to do when you're on your back and your arms are kind of out to the side. So this way they can kind of stay regulated and also are able to be in different positions. The next thing that's really important is like stretching and splinting to prevent any contractures or tightness. So the one at the top, the Bennett glove with the volar pan extension, is frequently one that I'll order so that they can remove the volar pan, and then the Bennett splint they can just wear either during the day or just when they're working on fine motor tasks. And then at nighttime, they'll put on the volar pan extension, and then it'll act as a resting hand splint. We make fabricated thumb abduction straps. We just take splinting material, or the splinting strapping material, and then we just sew the pieces together and make a little strap for our tiny little fingers. I'll make thermoplast resting hand splints, mitten splints, depending on what their hands look like. So usually the mittens will be more for like palmar expansion, really wanting to open up the palm if it's really fisted, or if they're starting to get the like hyperextension of the MCPs, an intrinsic plus splint would be good to use. We also use, like during treatment, the air splints and the posy soft elbows to help with weight bearing and to help them keep their elbow extended. But also while they're working on reaching, it helps them keep their arms stabilized so that their forearm doesn't go into pronation as much. And I'd say it's like hit or miss with the supinator strap. Sometimes they work, sometimes, most of the time they don't actually. Core support, really important. Obviously, we really want to have a really strong core and get those proximal muscles strong so that we can optimize the distal muscles. We know that they have stronger distally, but if they don't have a strong core, I think that's where we're starting to see the compensatory movements where they are really elevating their shoulders and trying to bring their arms up, and then their head tilts there. So then they're just trying to move and work against gravity, and it's not helping them out. So all of our patients typically will end up with a TLSO. Spios that we use a lot, especially with like the trunk stays on the back. And we also have a couple patients that we use Theratogs with and DMOs. We also use kinesio tape a lot. I found that when you like put it in the middle of the palm, it really helps them with their palmar expansion and with weight bearing. And we also use it a lot to help supinate and wrist extension. Sometimes with our little infants, we'll tape like their SCMs or their back to kind of improve the rounding of their really rounded shoulders, and then also to help with or to prevent torticollis. As they're starting to get older, so our little toddlers and then the small children, we're noticing that their MCPs from 2 to 3 are adducted, their MCPs 4 to 5 are adducted, and then 3 to 4 are abducted, that like Star Trek kind of sign. And they also tend to brace with one hand and forearm against their chest while they're reaching with the other arm as just another compensatory movement. And so these are just a few things that we do at our clinic. I like the egg chalk because it helps protect their joints from kind of hyperextending. It makes them do like a tripod grasp. For older kids, we make arm skates so that they can work on gravity eliminated movements while also increasing their independence and being able to use their fingers for fine motor tasks. the UEU or the cage, we use a lot to help prevent, again, that like the overpronation and stabilizing, as well as they're able to do gravity eliminated movements, and they are just also excited when they get to move their head around, kick their legs, use their arms. A few of my outpatients, so I ordered the mini easy grip scissors, and it works sometimes, but they usually end up like hyperextending their thumbs just because it's so wide. So then I ended up ordering the Hurock scissors, and they're amazing. And all of the parents that have had it have been like, where did you get those? And they've all ordered them for themselves. It's really cool. You cannot take it out of the suction, and then it's just like you can either use it like with your hands or just push it with a palm. But it really gives them a lot of independence. And then a lot of therapy to strengthen their intrinsic muscles. And the TheraBand, it's a really poor picture, but it's supposed to be of like it's a circle. And I have my patients put their fingers in it and then open it up and try to get over their hand or take it off of their wrist or their foot. One, it ends up increasing the strength in their hands and the intrinsic muscles, the really small muscles, while also working on like motor learning patterns for getting dressed. So they have to bring it up and over, up to their shoulder, and then they have to bring it back down. And they usually like and enjoy that activity. So these interventions are obviously really important to prevent joint contraction, joints, and increasing upper body strength. And future consideration should be given to upper extremity alignment and function for all children treated through newborn screening programs. And additional studies should be conducted to look at long-term effects of this new phenotype on fine motor and ADLs. And that's it.
Thank you so much to both of you. So at this point, we can open the floor for conversation for our first group discussion, and we are right on time. So fantastic job on that front. We'll allow about 10 minutes for conversation, and then we can move to our next set of presentations. And we do have a big enough group here. I know it's hard to see everyone. So happy for folks to jump in. If we start to feel like we're talking over each other at any point, we can switch to raising hands, but I think let's try having people speak up first. And if there's a need to raise hands, we can do that. And I do see that the Columbia group has raised their hand. So if you'd like to jump in, I think that's Jackie and Jean and their team.
Can you hear me?
We can. You're a little bit far away. If there's a way to get a little bit closer to a mic, that may be helpful.
Can you hear me now?
That is better.
Well, thanks. We wanted to see if our raise hand function works, so it does. But no, great talks. My question was towards Amy. Amy, excellent talk. I really am excited to see the work that you're doing, and I think it's really important. I have sort of a two-part question. It made me think of the Vigneault scale, and I'm wondering if you have any thoughts about how that could inform the development of the scale. Definitely the CP scale and the Vigneault scales are imperfect for SMA. So the first part of the question is, what are your thoughts? Did you look at the Vigneault scale, and what can you learn from that? And my second part to that question is that in your scale, this ordinal scale, it doesn't capture the impact of transitions on mobility. And so how do you think, and we know that transitions, especially in the higher end functioning patients, can really impact their community mobility or even their in-home mobility, how you might, how your scale is going to play out, or how might you be able to address that?
Thanks, Jackie. So to the first question regarding the Vigneault scale, I honestly don't have as much experience with that scale. I know the upper extremity scale a bit more than the gross motor scale, so I'd have to look into it more. I think of the upper extremity scale as more in-depth, sort of similar to the Brooks, right? So looking at discrete differences and different planes of motion for ADLs, but as a classification. So I guess the long and short is I'm less familiar with the Vigneault, so we'll have to look into that and see what the differences are versus the CP scale. And then secondly, for transitions, I think that's a good point, and then but also a challenging point, because I think of this type of scale as sort of a bit more of a classification scale versus a movement scale per se, and so I'm not sure how. I think what we need to do is we kind of did this initial analysis, and then we talked and we said, all right, now we need to bring in someone like Mike and really do sort of a multivariate analysis of all the different components of why there's differences across types and ages and abilities, and understand the impact of that more. So this was sort of definitely more of a global look at our 126 participants. One thing I didn't share is that 98% of them were treated with some sort of disease modifying therapy. So, but obviously the difference between a 4-year-old with SMA type 1 who's been treated, who's pushing in their manual wheelchair, is a lot just different than a 19-year-old with SMA type 3 who's pushing in their manual wheelchair, right? So I think there's a lot more we still need to understand, but at first glance, it seems that it may be really informative. And one of the main reasons that we kind of brought it to light, or the concept of it, was just because one of our ortho docs and a couple other physicians who we work with were craving an understanding of how a person moves or gets around in their environment from a very kind of broad clinical picture perspective, aside from SMA type. So in other words, how are they getting around in their environment? Are they walking mostly, or are they using a chair? And if so, what type? So good questions. I don't know if I really answered them, but love to continue to discuss this more as a group. And I think there's probably changes we can make already based on our initial analysis and the distribution of abilities.
Kristen, why don't you go ahead and jump in? I saw your hand pop up.
Took me a while to find my hand. Amy, I was just going to refer you to, there's a relatively new paper that was done on spina bifida, where they used the FMS and the different levels of the FMS, as well as cord lesion level and bracing ambulation level, like assisted device and bracing, because they're trying to move in spina bifida as well to sort of a new categorization. I think everybody's looking at, can we make like almost like GFCS levels in a way? But having just read that, because I was presenting something to my students this week, it made me think of a way you might be able to pull some interesting ways to just look at data out of that to kind of see how they've shifted their model, and also how they sort of have categorized the original FMS categories as related to functional level. So they didn't adapt the scale, but like the higher levels, like the 666, but it doesn't match like what you see in CP, but they had a process thinking about that. Just worth taking a look at it. It's by DS et al. And it's a 2021 paper. I can send you the link. Just
Great. Thanks, Kristen. And it looks like Tina did in the chat box share the Vigneault scale for the gross motor abilities. So to Jackie's point, for that scale, it does look like it includes more transitional movement. So Yeah, we found it to be really interesting and sort of a little bit, maybe not shocking or disconcerting, but just shedding light on the fact that there are quite a few of our participants, with seemingly regardless of their age or their their function in terms of type of SMA at least, who really are being pushed around passively in the community, not necessarily related to how long they've had SMA. And I'm not sure if other people experience that as well. We have a handful of people with type 3 SMA, for example, who, you know, they walk independently in the home and may get around a little bit at work without an assistive device. But they're not really quite ready to get a power wheelchair or even a power scooter per se. Maybe we've gotten them a manual wheelchair with power assist. Maybe they use a power assist sometimes, but it doesn't always work. And so then ultimately, if they're going for a really long distance or something, there's a woman I work with who's in college and she just has her boyfriend push her around. And, you know, obviously I'd like her to be more independent than that, but that's kind of her personal preference right now. So I thought it was really helpful for us to kind of think about the different factors other than physical too that may go into what someone chooses to do. And then alternatively for our treated infants with SMA type 1 who are now toddlers and preschoolers and are getting around their environment independently with like a Panthera or another rigid lightweight chair, but their families aren't quite ready to make the jump to a power chair for the community. And so because of that, they don't have the strength to get around in the community with a manual chair, but they're not really ready to have a power chair. And so therefore they are, you know, passively transported. So just kind of some interesting things to think about, and timing of intervention and exercise prescription as things are changing for this population.
Thanks so much, Amy. Megan, we're going to make you, I see your hand up there, the last comment for this section, since we're right up at the end of our time that we'd allotted for this. So you're up, and then Sally, you will be up next to present after Megan's comment or question.
It was kind of a question to the group, if anyone has seen the phenotype. It was in our pre-symptomatic newborn screen babies that we're seeing it, as well as our babies that have been that were symptomatic before starting treatment for Spinraza and for Zolgensma kids. So the poster is more detailed on the different cases, but we'd love to know if you guys are seeing it, or if it's only a Maryland thing. So.
I will say that we've noticed a lot of the pronation in some of our kiddos, even treated pre-symptomatically, as well as, you know, some mild torticollis as well. I haven't noticed the finger tightness.
I think that's the pitch, to have an OT on the team to be able to assess it, because I know I wasn't always noticing it, and then Julie be like, their hands are jacked up, and like they are, like and then as they get older, we're seeing how impaired their function is from like a fine motor standpoint. So, and even one of the boys was a nurture kid, so, you know, diagnosed and treated before, you know, 20 days of life and was not symptomatic. So I think it's something we should consider.
And something I forgot to say was they like cannot cross midline. I don't think they just can't do it. So starting young and trying to get them to do that when they're younger, I think will benefit them.
Yeah, that's an interesting concept. I think a lot of it has to do with core weakness, right? And the effort involved. But I know one thing we struggle with here is always the dialogue of when to introduce some sort of hand splint for the younger, for infants and toddlers with the ulnarly deviated position, and what's too heavy, and does anything work, or is everything too heavy, and is it going to make a difference anyway? And we have a lot of parents who really want to kind of tackle that and don't love the way it looks, and I always find it to be a challenging topic. So always looking for we're always looking for guidance on that.
You guys do fine motor, like at the Baileys or something? Just out of curiosity, are you seeing any delays in the fine motor development with your kiddos?
Yeah, we do the Bailey fine and gross motor on all of our newborn screen babies, and we definitely see delays. And then as they age out of the Bailey, we do the BOT, and they're definitely all below age match norms. Like the ones that are on treatment have gotten a lot better. The ones that were symptomatic, like normal 4 or 5 year olds that started treatment, that have improved on the BOT. But yeah, like none of our newborn screen babies are age matched, which is unfortunate. And we work to try to get them dosed before a month at the latest. Our goal is to get them, diagnosed and treated within 2 weeks with Zolgensma or Spinraza, whatever we can get first, and what the family's preference is. But yeah, we're seeing, definitely delays.
All right, well, great conversation. Sally, not to cut this off, but to make sure that we get to our other presenters, we'll turn things over to you now, and we'll have additional opportunities for discussion after Sally presents, and then Tina, you're after Sally. And if I can just ask you to be ready to tee up your presentation after Sally, we can roll right on through.
Are you seeing the correct screen?
Yep, you're in good shape. Thank you.
Great. Thank you. So I'm pleased today to present on behalf of a much larger working group, our poster titled The Development of an International SMA Bulbar Function Assessment for Interprofessional Administration. Starting with the background, progressive weakness in individuals with SMA can affect bulbar muscles involved in chewing, swallowing, and speaking. And we see this most notably in the most severe forms of types 1 and 2. The scarcity of validated and standardized bulbar assessments capable of systematically capturing clinically significant deficits in children and adults with SMA impedes the ability to monitor function and facilitate timely intervention, and also to capture potential changes on pharmaceutical treatment. So to fill this void, we've built a multidisciplinary team of international SMA experts with the purpose to develop an assessment of SMA bulbar physiology and function. And so this is our first report to date that describes the process of establishing this expert working group and getting consensus on relevant bulbar assessments to include in the evaluation of individuals with SMA. And this effort is part of a larger project to create a global scale for multi-center use in SMA. So we invited 54 international clinicians with experience in SMA to participate in a series of virtual meetings involving the evaluation of bulbar impairment. We utilized the Delphi method to engage the clinicians over multiple rounds of web-based surveys to establish consensus, and consensus was defined as an agreement among greater than 80% of the respondents. We used this method and consensus to categorize a type of bulbar assessment, the level of expertise of administration for the assessments, what equipment was required, if any, to administer, the application to SMA by functional status, what would be the appropriate age range to administer, and we rated scale relevance to SMA. And the Delphi method was then utilized to obtain consensus on item relevance and then classifying those items to key domains of bulbar impairment. So we've had 9 virtual bulbar function and SMA working groups occur in the last year, starting in June 2020, with multidisciplinary representation. You can see we've had 37 participate in total of the 54 we invited, mostly comprising of speech language pathologists, then physical therapists, neurologists and PhDs, occupational therapists, and we've been lucky enough to have 1 dentist. And then we also have representation from both the US and European colleagues as well. We presented a list of 55 validated assessments for bulbar function for potential relevance to individuals with SMA. This included 25 objective measures, 10 physiological functional measures, and 20 patient-reported outcome measures. And we then underwent 3 Delphi method survey rounds to gain consensus to evaluate the assessments and items for relevance in SMA, requiring minimal equipment and broad application for interprofessional administration. So I'm going to go into these rounds more detail. The first round included presenting these 55 validated assessments, and we achieved consensus on 5 objective measures, which you can see in the top box. And that includes 3 classification scales: the functional oral intake scale, the oral and swallowing abilities test level of impairment, and the neuromuscular disease swallowing status scale. And then we also identified, or the consensus was to include 6 patient-reported outcome measures, as you can see on the bottom. To the right includes the number of items that are included in each of those. And also in the objective measures, we gained consensus on looking at active maximal mouth opening and the 90 milliliter or 3 ounce continuous drinking test, where you count the number of swallows. Also in this round, we identified key aspects of bulbar function and categorized them into 6 domains. This included oral intake status, oral facial structure and motor strength, swallowing physiology, voice, speech, and fatigability. In the second round, we took those 5 objective measures and 6 patient-reported outcome measures and had a total of 115 items from those 11 assessments. And we achieved consensus on individual items selected by age groups. And for each item, we went through the relevance to SMA as well as the wording and discussed this amongst the group. And then we allocated those items that gained consensus to the relevant phenotype and age range subgroup. And we determined 0 to 2, 2 to 12, and greater than 12-year-olds were relevant for administering an SMA. And then the last round was done in 2 parts. We had 2 real-time web-based surveys to achieve consensus on classifying which domain each of those selective items went into. So this working group of multidisciplinary clinicians with expertise in bulbar function and SMA used the Delphi methodology to reach consensus on assessments and items considered relevant for SMA across all age groups, and we organized that into 6 domains. We are still currently in the thick of this and in the process of going through, and now we're including the evaluation of voice and speech abilities in individuals with SMA. And we also plan to invite the patient and caregiver perspective when we have a more near final item bank to review. Our future steps include piloting this new assessment internationally, moving towards validation and reliability of the new bulbar function scale. And this working group will support the advancement of assessing bulbar function in children and adults with SMA by a variety of professionals. So I'd just like to say this study was supported by QASA and the International SMA Consortium, which includes the PNCR, SMA Reach in the UK, and SMA Telethon in Italy. And we gratefully thank all the clinicians who participated in the bulbar function and SMA working group. Thank you for listening.
All right, thank you so much, Sally. We appreciate that. Tina, we'll go ahead and turn things to you. It looks like you are ready to go. Thank you.
Tina, you're on mute.
You're on mute. There we go. Thanks, Amy.
Okay, is that better? Sorry.
That's great. All good. Thank you.
Talking to myself again. Thank you guys so much for inviting us to present our work on strength testing or strength assessments in SMA for adults receiving nusinersen. I am presenting on behalf of our Stanford team, particularly Dana McDonald-Parker. And so she's also on the line and happy to take questions whenever we get to that portion of the talk. So our objective in this was really to describe isometric strength assessments while patients are being treated with nusinersen and understand the relationship that it has with some of the functional motor measures. I went ahead and skipped the background because you guys are all experts in it, and for the sake of time, I thought it'd be better to get input to discussion. So that's why there's no background to this. But you can see here our methods. We recruited 43 participants. There were a total of 113 observations with a mean age of about 36 years of age. All these patients were treated with nusinersen. We decided to analyze the data by functional level because when we looked at as a whole group of 43, even though statistically the numbers looked better, the variability was just so great that it was just really hard to extrapolate any information that came out of it. The device we used was the handheld myometer called the MicroFit, set on the low intensity level because of the ability to get the lower weight of some of our weaker patients. You could see here divided into 3 groups. The numbers are quite small. We have 17 in the non-sitters, 16 in the sitter group, and 10 in the walker group. Okay, you could see here our follow-up for on average was about 23 months for patients who were treated for about 23 months. 35 of our participants had at least 1 year of follow-up and 17 had 2 years or greater. What you can see here divided into different functional groups is that the non-sitters, sitters, and walkers, that primarily if you focus in, sorry it's so small, in the flexor group, you can see the flexor group better differentiates the functional groups than some of the extensor groups. We decided to look at correlation just to better understand what of the major muscle groups we looked at, which was elbow flexion, elbow extension, knee flexion, and extension, and how they relate to the RULM and Hammersmith. So in the sitter group, we found that there was a moderate correlation with RULM and Hammersmith for all of the muscle groups except for knee extension. And you can probably imagine that's because the knee extension was incredibly small whenever we did the measurement. When we looked at the walkers, we found there was a very low correlation with the RULM. However, there was a really strong correlation with the Hammersmith for both total knee strength as well as knee flexion. And then there was also a strong correlation that existed between elbow flexion and knee extension. Some moderate correlations were found between knee flexion and extension, and as well as elbow flexion and knee flexion. We wanted to see over time what the changes looked like. So we did a linear mixed model regression to assess some variables that were controlled for this regression, which included duration of treatment time, age, and sex divided into these functional groups. What we're showing you here is that these are the groups that showed statistical significance seen in the treatment duration. When looked at, when the other variables were compared, meaning age and sex, they were non-significant. Keep in mind, these numbers are extremely small. So despite the fact that they do show at least a 0.05 significance, we're really looking at this to tell us what muscles may respond to treatment rather than saying that these specifically show statistical significance because our numbers are so small. And you can see here, there's variability that exists throughout the assessment, but primarily if you look at the muscle groups that seem to change, it may make clinical sense for us because most of them are the flexor groups. So we have elbow flexion that's on top and knee flexion that's on bottom. But most of them are showing that kind of change. And you can see here, just a general look at it, it seems to be pretty consistent with what what our knowledge base is about strength assessments in SMA. It stays pretty flat. And there's just a few outliers here that we did verify were true assessments. But besides that, in general, within this time frame, you can see that that's pretty flat, despite the statistical significance, which is also very, very small. Okay. When we looked at the strength changes in the walkers, again, we do find the flexor groups showing the most statistically significant change. And that's both in the elbow flexion group as well as the knee flexion group here. And again, you're seeing potential change that's occurring with these slopes, but most of the time they're pretty flat. And when you looked at the variability in the groups, elbow flexion honestly had the most variable of all the muscle groups that we looked at. So in conclusion, what we're seeing is that there is maintenance of strength, especially towards the flexors. And we see that the flexors are the primary responders. And there's an emerging trend towards increased strength. We hope that with a longer period of assessment, we'll be able to discriminate that better. That's also what we found in the ability for the strength to discriminate between functional grouping types. And there is a great variability that exists in all muscle groups, particularly in the elbow flexion. Nusinersen treatment duration of all the variables we looked at was the one that significantly impacted strength in the muscles. And what we plan on is future analysis to look at the strength changes that are associated with 6-minute walk and time tests that we also did as part of this study. And then we're planning on looking at % predicted strength and to better understand how strength is changing within these within patients with SMA. And of course, we couldn't do this work without the support of Cure SMA and SMA Foundation and the patients who spent a lot of time with us doing these evaluations. I think that's it.
All right, thank you so much, Tina. So again, we will open this up for conversation, and hands seemed to work just fine before. If folks would like to jump in, again, feel free to do that. Kristen, you're very quick that time. You found the hand quickly.
My question should be quick too. Tina, for your group, I noticed it looked like your graphs didn't show much of a right-left difference. And I'm asking if you, like, statistically, do you know if they did? I know recently we looked at strength just in our ambulators, and we had, like, our graphics were hugely different between right and left. Like, they had one side that continued to get better and one side that stayed the same and was much weaker overall. So I was just curious if you saw that difference or not, because your graphs look kind of flat from one side to the other.
Yeah, Kristen, that's a, oh, good. I thought I was on mute. That was a really good question. To tell you the truth, that was one of the objectives in our analysis that we haven't had time to take a look at, but we were going to compare left and right side, as well as look at handedness and see if there are strength differences or correlations related to handedness as well. Dana, with our preliminary analysis, are you able to expand on that anymore?
Yeah, so we, like Tina had mentioned, we had kind of just started delving into that prior to this. And we, from like really early gatherings, it doesn't look like there's a huge difference other than, you know, a dominant side being stronger. But for the most part, yeah, it's looking like it's going to remain pretty flat. But I hesitate to say anything because it's still pretty preliminary there.
I always forget to raise my hand, but I have a question. So now I'm raising my hand, but not through the Zoom chat. Sorry. I've gotten good at Zoom, but not that good. So I had a question regarding for Tina. Well done, both of you. For the elbow flexion strength and the fact that there was the greatest variability with the flexors, do you think part of that, or something that we could attribute that to, is that tends to be a stronger muscle than some of the others?
I think overall, if we were to choose one muscle group for all functional groups, we'll probably choose elbow flexors. That one seems to be the best responder of all of them. And you know, elbow extension, to tell you the truth, it was just so minor. I think the compensations, as most of you probably have done manual muscle testing, we do it in the standard 90-90 in supine, and a lot of times you kind of have to control for that external rotation, the elbows going up, and then throwing in the shoulder as well. And so I think because of all those compensations, that may lead to some of that variability that exists innately from patient to patient. But in general, I think altogether it's because it is the stronger muscle group. And I think I was trying to look at the variability that we have in elbow flexion, and it is quite high, or that may be one of the higher muscle groups with variability.
Thanks.
Sally, we're fast. No one asked any questions.
Yeah, I actually could probably add a comment to the strength discussion if that's okay, Tina. And maybe Leslie wants to chime in too, but I feel like years ago when we were just starting to look at strength measures in the early phase 2 studies, CS2, one thing I was noticing in this young group was perhaps like a shift in the quad to hamstring ratio. And I know we've never formally looked at that as a group, but I wouldn't say I've noticed this for all patients on treatment, and definitely I haven't really seen it clinically in the adult population, but it was the children where I'd be a little shocked at how strong their quads had gotten in comparison to their hamstrings when they were originally so weak prior to treatment. And I was just curious if anyone else has anecdotally or clinically noticed similar findings.
We 100% we noticed that, yeah, in almost all the patients that have been treated. So, and it's something I bring up with the parents and families because they're excited to share it. And when I think back to the natural history, it's just that it's not that active arc of motion for knee extension is just not there. So it's interesting for sure. It'd be interesting. I mean, really the only functional item that we capture that on is like the chop and tend, right? In terms of that activation. So, but we've gotten away from doing myometry. So it might be nice to consider it. Revisiting it as long as we can understand which muscles are best and when, because that's my beef with myometry is it does take up a lot of extra time.
We try to address that. Well, we are trying to address that by looking at change scores between hamstrings and knee extension for different muscle groups. But granted, we're so limited in our, N of 10 and 15 on it. But I mean, that is a really relevant clinical question that hopefully with time and more patience. Megan?
Yeah, I'd agree with what you said, Sally and Amy, but I would say that the kids that are on Scholar Rock that have gotten nusinersen for an extended time, their hamstrings are actually getting stronger. I don't know if anyone else has seen that. So it's actually a little bit more like asymmetrical. They were stronger in the hamstrings, and so they kind of get more strong, but the quads are better, but not able to overpower is what we've seen.
Columbia group, I think, was next.
Great.
Jackie et al.
I was thinking, to Sally's point, with the quad to hamstring ratio, that's a good one. I mean, it actually, we had students here that presented at CSM looking at that ratio in untreated patients and how it differs from the normal quad to ham ratio. And it just made me think that nothing matters unless you publish it, just putting that out there. So, but then thanks for Sally, and an abstract presentation is only a promise for a paper, but I'll just put that out there. But I wonder, thank you both, it was great, to the strength topic. I guess I'm not surprised, right, that the flexors, elbow flexors and hamstrings maybe were more responsive to treatment, and going forward, maybe there's some denominator we could have for the degree of atrophy or weakness relative to improvement, because it really matters. I mean, if the quads are so decimated, then its propensity or ability to improve is pretty low. And also then it makes me think about proportional change, right? So it's all relative to where they started. So.
Yeah, we thought about, I guess we also looked at total lower extremity and total upper extremity score with kind of the thinking behind if you combined it kind of dilutes the ability to assess the muscles that are actually responding. And I feel like with the lack of response from the both knee extensors and elbow extensors, just because the strength was so minimal to start with, that may not be the recommendation to have a combined strength measure for upper and lower limb versus the stronger groups who seem to be responding.
I still see a couple. Yeah, go for it, Tina. I was going to say I see a couple hands up, but please call on people.
Liz, did you mean to put your hand up?
Yeah. So
Okay.
just one of the things I think just to kind of project down the road to think about too is I think anecdotally we have seen some differences in strength gain patterns between the different treatments as well. I think, we've noticed that kind of the proportions are different with the kids who receive Zolgensma versus Spinraza too. So just kind of a comment of thinking down the road further too, of being able to compare those would be kind of an interesting idea there as well. I don't know if anyone else has noticed that too, but I know we've talked about that some in Boston.
That's interesting. We don't get a chance to see that as much because mainly Sally and I see adults. And now that Evrysdi is approved, some of our adults are switching over, but mainly our adult population, we're all on nusinersen. So that'd be something to look out for.
Yeah, Dr. Ghosh and Dr. Darris and I had a conversation about that maybe even almost a couple of years ago now, just the response and pretty rapid response to return of anti-gravity hip flexion and leg lifting and supine in some of the infants and toddlers that were in the infant biogen study. And just the fact that the medication does go into the lumbar spine, and how initially when we had some of the participants in the gene therapy study, we weren't seeing as it was interesting as rapid of that change. So, but then of course not all of the kids with type 1 in the nusinersen study got that same sort of rapid response, but it was something that really jumped out. And Dr. Ghosh kind of simplified it to me, and just the fact of where the medication was going or directed to. And I hadn't thought of it as simply as that, but.
Yeah, we debated for a while because we were trying to decrease our assessments, and the divide between should we do manual muscle testing and handheld, or how I'd also be curious to see of all the PTs and OTs here, do you do manual muscle testing and strength assessments, or a combination? Because that's what we're missing, because we don't do manual muscle testing now as part of our exam. Kristen, I think you're up.
So my question was in response to your comment about right and left and handedness. So interestingly, we only looked at a small group, and it was in response to a query on something. And interestingly, we were debating right versus left. Do you look at them separately? Do you put them together? So the feedback we got when we actually looked at our data is that the handedness didn't seem to determine the stronger side. And so we then thought that maybe we need to combine them, because how then do you choose? You can't just randomly say, okay, we're going to do everybody's right side, or we're going to do everybody's left side, because we don't know why there's that asymmetry. And maybe that asymmetry is not related, typically we sort of think of handedness, but there's maybe a lot of factors like scoliosis, or where they're more stable in stance, and different things like balance and different things. So I think it's an interesting question, but it's really hard to just say either you divide them and you look at both sides separately, or you combine them. And I think that's another question that needs some more information. We just use myometry.
Kristen, so did you decide to combine them? Is that what you said? On right and left combined?
in response to this query, we are combining them because our statistician thought that maybe that was a better route, only because we couldn't say at first we thought handedness, but we can't say that handedness is like everybody got stronger based on handedness.
Well, and then we have so many patients who consider themselves ambidextrous. And so then there's that group.
Right. And then we started to think about the other factors and thought maybe that made sense. So for this purpose, we're combining them. We don't know if that's the right way. We had to go with something to answer a question, but that's why I threw it out there. It's something to think about. All their other compensations and asymmetries, it's hard to really know.
Yeah.
Well, good discussion continues. We are just a couple minutes past the time to move to session 3. So I would propose that we move on to that. And for anybody that needs to turn their camera off and just stand up and stretch a little bit, Jessica, I think we'll all be focused on what you have to say. I know when I turn my camera off, that's usually the reason. I just need to move around a little bit and I don't need to be distracting for everyone else. So please feel free to go ahead, begin sharing. We'll have Jessica, then Krista, then Kara for the session and some final discussion prior to closing remarks.
Hey, thanks. Okay, so my poster was on a child that I have followed for a while who ended up having hip reconstruction last summer, and sort of looking at the surgical timing and the rehab that we did and then his outcomes. So this child was diagnosed with type 1 at 8 months of age and began dosing at 18 months of age. During that 0 to 3 time frame, he received early intervention for his therapy services, including PT 2 to 3 times a week during that time period. Then from the age of 3, when he aged out of early intervention, until the time of his surgery, when he was just a few days shy of turning 5, he received PT in his home 3 times a week. And then in addition, he received a little center-based feeding therapy, some school therapies, and he did not have, I would say, formal aquatic therapy, but he has access to a pool and was in there daily. So lots of aquatic opportunities. So I know yesterday I got to listen to the musculoskeletal panel and listen to Dr. Snyder talking about how he makes a decision for someone is, ready for surgery. And I was sort of happy to hear that this child, I think, would meet all those criteria that he talked about. He had a very high Reamer's index. He was over the age of 4 and he was having pain with function. So previously he was able to be in his stander for easily 45 minutes, multiple times a day. And now we started seeing that at about 20 minutes or so, he was complaining about pain in his hips. So that sort of initiated the cascade that this was time for his hip surgery. So preoperatively, of course, COVID threw a bit of a wrench in all of our plans last summer, but we were able to get goniometric measurements as well as a pre-op CHOP score for this child. And so he had his surgery last summer, and for the weeks 1 and 2 after his surgery, he was in his custom brace, 100% of the time. At week 2, the family was able to initiate some real gentle passive range of motion, but otherwise was in the brace. And then at 6 weeks, he was able to do some sitting, but then was still in the brace when he was in supine. And then at 8 weeks, he was discharged from the brace, and that's when we started back in person physical therapy in his home. So then all the rehab I'll talk about from now on is from that 8 weeks to 20 weeks post-op time. Here is his post-op x-ray. You can see obviously very successful orthopedically with a 0% Reamer's index, and then with function he had no pain. Even when we first began initiating his standing program, he no longer had pain in his hips. As you can see, he did have some plating on the right, which I guess just speaks to, I think, also with Dr. Snyder and some of the other, orthopedics yesterday we're talking about with the, just how fragile those bones are. But, happily, he still had a really great outcome despite, that issue. So here is a picture of my patient. And so when we did PT interventions, we really have followed the standard of care guidelines. So for aerobic exercise, he uses the pool, real consistently, almost daily, for his aquatic or his aerobic exercise. Strengthening, we try to be real creative with him. We use a lot of gravity eliminated, against gravity intervention. This photo is of him on his bike that we use for a lot of active assist movement, as well as some strengthening. We use a variety of platform swings that the family has to, of course, challenge balance, but also we were able to sort of modify the amount of weight bearing he was doing and really getting some nice glute quad gastroc activation over those swings. For stretching, we really pretty much just do positioning strategies throughout the day. We did balance activities, and then of course he had his daily standing program. So in terms of his goniometric measurements, we saw, about a 20-degree change in passive range of motion into hip flexion, between 15 and 20 degrees into hip extension, and then that popliteal angle changed by about 10 degrees. And then in terms of his CHOP and 10, we have his July measurement. That was his baseline right before his surgery. The next time we did it was in September. And so you see he had a point or two lower there, which makes sense, right? He was immobilized for quite a while, but what we were really happy to see then is by November, not only was he at baseline, he was several points above his baseline. And that's it. So we're just sort of looking at his overall outcome here, that he had a really nice outcome with the protocol that we utilized, and the timing of his surgery felt like was really successful.
All right. Thank you so much, Jessica. Appreciate that. Krista, you are ready to go. Thank you.
There we go. Sorry about that. All right, can you all see my screen and hear me?
Yep, it looks great. You sound great too. Thank you.
All right. So I am just sharing my poster presentation, the use of ischial weight-bearing KAFOs to progress standing and ambulation abilities in 2 children with spinal muscular atrophy. Here's a brief summary of the individuals that I'll be highlighting today. The primary characteristics that were similar between our 2 individuals that set them up to be potential candidates to try this system to progress their participation in standing included their ability to independently sit hands-free and having only minimal lower extremity contractures. The table below highlights the primary differences between the 2, which included SMA type, their age, timing of diagnosis, and timing of initiation of drug treatment. So case 2 is functionally stronger as a type 3 who gradually lost the ability to ambulate over time. He was also older at the time of diagnosis, older at initiation of drug treatment, and then also at an older age when we initiated this KAFO system for standing. So our primary goal for trialing the use of the ischial weight-bearing KAFOs for these 2 individuals was to allow for increased participation in supported standing opportunities in optimal alignment. So the benefits of participation in supported standing for the neuromuscular population is well documented and includes the benefits listed here on this slide that we all know of, but we really wanted to provide an alternative version of supported standing that allowed for more dynamic participation and mobility, which could potentially provide additional benefits to those already known for the traditional static standing within a device. And some of these additional benefits include not only providing that stretch to the lower extremities and weight bearing, but also allows for that intermittent loading to help with bone development. It also provides as a method for strengthening and aerobic exercise, which is also recommended per the SMA standard of care. And also this system can allow for improved participation and access to multiple different environments, allowing for improved engagement with peers in an age-appropriate position. So here, this slide just demonstrates the standing progression for case 1 to kind of highlight my physical therapy thought process. So initially starting in static standing in a standard to then including more dynamic standing and weight bearing opportunities. We initially trialed dynamic standing with bilateral solid AFOs and bilateral knee immobilizers and parallel bars, while I manually provided ischial containment. However, this setup did not provide optimal alignment, allowing for him to fall into quite a bit of knee flexion. So I sought collaboration with orthotics to fit him with bilateral ischial weight-bearing KAFOs, which you can see in the third picture. And in these devices, he was able to immediately stand independently, and you can appreciate the improved lower extremity alignment with this system. And then to further progress independence and mobility from here, the addition of a reverse walker allowed for independent exercise ambulation for short distances with supervision for safety. So the close collaboration between physical therapy and orthotics was crucial for success. And this slide kind of highlights some of the primary roles between the two. Orthotics provided consistent fine-tuning of the braces to accommodate for strength, range of motion, and alignment changes over time. They also provided insight into componentry and sagittal alignment in order to provide an optimal brace for alignment and mobility. This specifically included consideration of the weight of the devices on functionality and the ability to step, and the adjustment of the anterior inclination of the brace or system with the use of heel lifts to accommodate for significant extensor weakness. And I have seen how even just a subtle change within how much of a heel lift you give to shift them anteriorly can have a huge impact on how comfortable they feel at independently standing in these devices. Physical therapy provided weekly outpatient sessions focused on progressing their independence, safety, and mobility within these new devices, with close attention to monitoring their alignment and symmetry. There was a lot of safety training with fall practice that was included, and then also just establishing a progressive home program based on the SMA standard of care. And then I also performed monthly 10-meter walk tests to track changes in their speed, endurance, and efficiency of ambulation over time. Here's just a detail comparing the results of both of these cases. The KAFO design varied slightly between the two. For case 1, we used unilateral uprights to reduce the weight for our younger individual, and we used bilateral uprights for the older individual due to him having fixed genuvalgum, as well as the need to support his overall body weight. Both individuals were able to achieve independent hands-free standing with the use of these devices immediately, so at their first fitting appointment. They both also demonstrate gradual improvements in gait speed, efficiency, and endurance with the ability to walk further in less time. And you can see that demonstrated here in this 10-meter walk test graphs. The capacity for ambulation achieved between these two were different. As we highlighted in case 1, now ambulates short distances with KAFOs and a reverse walker, whereas case 2 now walks household different distances. And it's a little difficult to appreciate within these graphs, and thinking back on it, I should change the scale so you can compare a little bit more easily. But on case 1, he takes on average about 3 minutes to walk 10 meters, whereas case 2 takes on average about 30 seconds. So here are just some short videos. Hopefully they play.
Where's the floss?
Each of them showing off their new mobility within their KAFOs. Sorry for the sound. And I just want to thank these individuals and their families for their compliance and motivation and comfort sharing their successes to teach others. And then, so in conclusion, as we all know, the world of SMA is constantly changing, and we feel it's our clinical responsibility to collaborate, share our outcomes and think outside of the box toward alternative interventions. And for anyone that's working with an individual with SMA that is an independent hands-free sitter, the use of ischial weight-bearing KAFOs should be considered to progress participation in supported standing. If you do decide to use them, closely monitoring symmetry and weight line forces is needed, and consistent fine-tuning and adjustments over time are required. And you can see in this example here, the asymmetrical weight bearing and how that could impact his trunk and knee alignment. So working very closely with therapy to maximize that symmetry, and then any modifications to the devices. We also recommend tracking outcomes with your intervention. So we use the 10-meter walk test with only one of them. I also did the 2-minute walk test, but tracking those outcomes over time. The main things that I noticed that created either a plateau or drop in their mobility were associated with a decrease in PT frequency, decreased standing practice at home, a rapid period of growth, or just adjustment time to their new braces. And then finally, in order to have that successful outcome for this intervention, kind of some key things that are required are only minimal lower extremity contractures, a motivated patient and family, and a supportive rehab team, including that close collaboration between physical therapy and orthotics is essential. So thank you for letting me share.
Thank you so much. And then Kara, are you ready to go? Oh, are you double muted by chance? Looks like you maybe said something, but I couldn't hear anything.
See my screen and hear me?
Yep, we're good now.
Okay. So thank you for the invitation to speak today. I'll be discussing the use of telehealth during the COVID-19 pandemic to secure durable medical equipment for patients with spinal muscular atrophy. I'll advance the slide here.
Right, and Kara, just before you get started, you're just a little bit fuzzy. It sounds like maybe you're calling from overseas. Is there a way you can get closer to your microphone? Just want to make sure we can all hear you clearly. And we can hear you okay. There's just, it sounds like there's wind or something like that.
Can you hear me better now?
Yeah, it's a little bit louder at least. That's good.
I can put a headset in to sound better maybe. Would
that may be helpful.
Okay.
Yeah, there's a lot less background noise there.
Okay, can you hear me?
Thank you. Yep, far better.
All right, so as part of the Columbia University Irving Medical Center, SMA Clinical Research Center, and Pediatric Neuromuscular Clinic, part of our role is to assist our patients with their DME needs, among other things. So specifically, a well-established team, including a physical therapist, occupational therapist, and assistive technology professional that have worked closely together serving this community of patients with SMA, wanted to know how they could assist an immediate need to attain durable medical equipment during the peak of the COVID-19 pandemic. Why? As we know, healthcare does not pause during a pandemic. Progressive neuromuscular disorders such as SMA continue to evolve, children grow, and needs are ever changing. In the virtual model that many of our children needed to adapt to during this time, there was a lack of access to schools, which impacted the ability to obtain new equipment. For many of our children who live in New York City, their equipment is actually stored in school, so they were suddenly found without their equipment. And many wheelchair clinics during this time were temporarily shut down as staff was redeployed to frontline work. So it was clear that the process to secure DME needed to be modified and quickly, but it was important for the core principles to remain the same. These include a clinic visit with a provider, an equipment evaluation, powerful justification through a letter of medical necessity or an LMN, strong knowledge of our patient's medical history and current level of function, and a trusting relationship between the team and the family. This flow chart on the right shows the process beginning with the standard of care visit through delivery. All standard of care visits at this time were shifted to telehealth, as was done across many institutions, and the equipment evaluations were done through one of two models, either the 100% remote model or 50-50% hybrid model, which I'll go into more detail about. Some people required a second evaluation, which could have been for one of several reasons, either a clinician opinion, thinking that they needed more practice with equipment, family request to trial additional equipment, or because insurance required additional documentation. Paperwork was then put together, which included the LMN, and submitted with the goal of hopefully approval and delivery without the negative impact of the global pandemic. The majority of our visits were the 71% were the hybrid model, where the PT and OT were present via telehealth and the ATP was present in person. Caregivers and family members were often present as well, just as they would be at a traditional clinic visit, and when applicable, home health aide and nurse were also present. This was essential as these additional caregivers were honorary therapists assisting with positioning, transfers, and camera angles, helping with optimal viewing. Pre-planning meetings occurred prior to each visit, both with the family to help set expectations for the visit, what they could expect, how best to set up their environment, and with the team to determine what equipment would be trialed and set up safety measures like who would watch vitals, how long a patient should be sitting up, and deciding if a visit should be called if it was deemed unsafe. Environment was either in the home or outside the home, and visits took about 60 minutes. So this snapshot of time was between March and December 2020. In total, there were 18 individuals evaluated, ranging in age from 2 to 19 years old. There were a total of 24 evaluations, because some people required an additional evaluation, and 23 pieces of equipment were ordered. This table on the right goes into more detail about these evaluations, and this figure on the bottom shows the equipment that was ordered and how much. But I'll highlight two exciting achievements. The first was the approval of a standing power wheelchair, which is not an easy feat, which occurred after 2 hybrid evaluations. A second evaluation was necessary in this case so that the patient could determine the correct chair for her growing needs during a transition to adulthood in life, moving from primary schooling to higher education. She had the benefit of receiving this chair and determining the best chair that would give her the most independence. Delivery occurred in less than average time, as you can see here. From equipment evaluation to delivery was 78 days. For our sample, the mean was 109.5 days. And according to New Motion's website, average delivery time ranges from 77 to 175 days, so it is less than their average as well. The second achievement was the approval of a power wheelchair for a child less than 5 years old, which occurred after only 1 hybrid evaluation, which emphasized the continued importance of early power mobility, which has been shared by the work of Dunaway and others, and as alluded to earlier, that children continue to grow and they need the ability to explore their environment. He had the benefit of being able to practice utilizing the chair, demonstrating skills through narrow New York City hallways and doorways, which may have shown even more skill than he would have if practiced using it in our wide clinic hallway. Delivery also occurred in less than average time at 96 days. To conclude, this works. We acknowledge that a long history with many of the families and between the team was fundamental to this success. After all, this shouldn't replace traditional evaluations. After all, a majority of the visits occurred with at least one person providing direct hands-on care. It can, however, be an adjunct model of delivery when needed. This is especially valuable during flu season, when many families have often stayed home in the past to remain healthy. This is a beneficial model to use currently as we transition back to in-person activities, and in the future, anytime it may be difficult to access the clinic, whether it be due to illness, weather, or any other reason. I'd like to thank these team members and mentors who have helped make this work possible, and most importantly, the families and patients who have participated in these studies. Thank you.
Thank you so much. Another good presentation. So we will open up the floor for some additional conversation. We will allow about 14 minutes for conversation and just a few minutes for closing. Before we wrap up, as I mentioned, we have an invitation from some of our program leads to participate in an ongoing activity. So we'll share a little bit more about that, but we'll open the floor to conversation at this point.
I had a question for Jessica. Thanks for your presentation on the hip case study. I think the protocol for the surgeon you work with may be a little different than ours, and I was curious if you knew more about it in terms of, or if you could elaborate on the level of immobilization that they have the patients sustain for, it sounds like the first 6 weeks of life. Not weeks of life, sorry, end of day, weeks after surgery. So are they completely like 100% immobilized, like no passive range of motion?
For the first 2 weeks.
Okay.
Is my understanding, yes. And then at 2 weeks, they're doing passive range of motion, but it's kind of like Dr. Snyder was doing sitting or 0 to 90, right? Hip flexion and sitting immediately.
He's a bit
that
more,
wasn't quite what we were doing.
Sorry, I got the impression that it was 6 weeks of full immobilization, and from what I've understood that that can lead to a lot more stiffness and
sure, that makes sense. So they were doing passive range of motion.
I see.
Very consistently after 2 weeks.
After 2 weeks.
Yeah, I think the other thing too, Amy, we were actually chatting about this yesterday after Brian's talk, because I think it's, there was a pandemic. He had a little bit of a fracture, and then I think this was also the first one that Dr. Larson participated in at our site. So, but she was also like, on her way to have a baby almost. So I'm not really sure. Like, I think they're still working out the protocol. I think maybe it would have been different if there wasn't a pandemic. It's hard to know. Like, we've been trying to get them to give us more information on that. That's why it was actually good listening to that yesterday.
Makes sense. And it sounds like it's a custom abduction splint that she uses versus like the rhino or a wedge.
Yes, it is a custom splint. It went up to the mid trunk, actually.
Oh, wow.
It's similar to the kind of splint they've used for kids post-op here at Lurie. And so I think they just use the same model. It's fairly lightweight. And I think that's why. And they mold it right at the time of surgery.
Interesting. Okay. Yeah, our facility uses just more off-the-shelf things. So.
And I am seeing one question that was written in the chat that I believe is for me. They are asking whether the patients that I presented had the ability to stand without support, without KAFOs, or with lower bracing. So I think I understand what that's asking. So that's what varied a little bit between them. So the weaker, younger case one was unable to support any weight through his lower limbs without full trunk support. So I mean, 0 to 10%, very minimal to none. Whereas case two, he did previously achieve the ability to ambulate, had lost that over time. He could, with AFOs or even barefoot, be able to just like hold mom or my hands and maintain standing for a very brief amount of time for a stand pivot transfer. But the weight bearing again was very limited and poor alignment and not functional or sustained for longer than a brief period. And then someone else wrote in another question for me. So was their sitting balance, what was their sitting balance and upper extremity strength? Both of them have pretty decent sitting balance. They have really great lateral writing and protective reactions, pretty difficult AP control for postural alignment. They, I would say, at most can translate their trunk like 30 to 45 degrees anteriorly before they lose head control. So pretty significant extensor weaknesses, which is why they really depend on that ischial support and pitching that whole system anteriorly to kind of compensate for that weakness. And as to their upper extremity strength, that was again a big variable piece between the two. The weaker case 1 is unable to achieve prone on elbows independently. He can maintain it inconsistently for like 3 to 40 seconds. If we get him prone on elbows, he can hold it. Whereas case 2 can independently reciprocally creep. So has that ability to take pretty good weight through his upper extremities. So yeah, those were some differences between the two, but I thought it was interesting, like the similarities that they had, the differences that they had, but they could both have a successful outcome and kind of utilize this strategy in a different way for mobility. I hope that answered your question.
I actually had a quick question for Jessica. Nice work, everybody, for sure. Jessica, with your patient, I'm curious as to your choice in the CHOP and 10 since they were scoring in the 40s, and was he able to sit unsupported? Did you do the Hammersmith? Would you consider doing the Hammersmith?
Good question. I will say that I did not perform any of those outcome measures. Actually, Kristen did. And so we had his CHOP and 10 scores from, like all the other times he had gone into clinic. So that was really why we used it, to be able to see any changes, especially if there was like a big drop. But Kristen, do you guys use for patients similar when he comes into clinic, do you use the Hammersmith?
Yeah, we do, but I can tell you, Jackie, he wouldn't have scored. We had this discussion, I think, in one of so the first time I actually assessed him remotely while I told Jessica what to do because he was still, we are still in lockdown, but he's always done the CHOP, and I could tell you even now, he would not score very high on the Hammersmith. We've talked, I know at like one of his last follow-ups, we actually, every time I would ask his dad, okay, can he do this? Can he do this, to know if we should move him to the Hammersmith? And I would say he would probably get maybe a 4 on the Hammersmith. If he's lucky, maybe a 6. He doesn't roll all the way over, right, Jessica? That's my, yeah, I want to make sure I'm not mixing
That's right. Mm-hmm.
Yeah, and he looks stronger when you just look at him than he is, because I always expect him to get higher scores. I've been impressed, like when I think of him when he was little, as to where he moved on the CHOP since he was little. He was one of those kids that was kind of iffy between like a 1C or a 2A, like initially. He has very good head control, but his body's very weak.
Thanks. I mean, that's great. It almost makes me think that there's this niche of a phenotype that, because he doesn't have contractures or like obvious, like awful contractures, he's still little enough, and if you want gross motor function, he's at the floor of the Hammersmith. So the CHOP and 10 actually works there. So I think that's a nice little gem to highlight.
And now that some of his range of motion improved, obviously, from the surgery, we would anticipate that potentially with more doses of nusinersen that he may hopefully get stronger and be able to move and do more on the Hammersmith. Remember, he was probably really limited by, if I were to do him on the Hammersmith, I would have probably right away like knocked out 6 or 7 items because of contractures, because his contractures were pretty significant just before the surgery. So that's a nice advantage of the surgery. I'll make one other comment about Krista's patient. So her younger guy came to my PT class when he had just gotten those braces. He hadn't had them that long at that time. And I've actually worked with kids in the past that had used ischial weight bearing braces, but not on drug. And so at the time, I don't even know if he was on drug then or not. Was he, Krista? I can't remember. I don't think he was.
Yeah, he had recently started. He'd been on it about a year.
So it was very different to me to see and very exciting, but I can just remember because my automatic response in the past with ischial weight bearing braces is you got to be like right on top of them guarding. And he says to me, no, I can walk by myself. And I said to the students, somebody needs to guard him. He's like, no, I can do it myself. And in my head as a therapist, I wasn't convinced, but I was super impressed because it was very, very different than a non-treated kid in initial weight bearing braces versus a treated kid. And he had a lot of confidence, which I think that's a really cool thing that came of it too very early, is that he was confident enough to stand. Like you said, oh, I can stand and let go. How long can I would ask his mom, like, how long can he stand? Can he stand by himself? How long can he do it? And then I think he really was in sort of that, like, I want to show off what I can do. And he stood there and the students counted. And it was super impressive because in the past, I don't think I've had kids. I've had a few that could do it for 10, 20 seconds, but he went to a good minute and he was really quite proud of it. And that was very early, that was when he first started.
Yeah, the day of fitting, it was an immediate achievement of independent standing with quite a bit of confidence with both of them. And I did initially, because I had never worked with anybody in this setup before, I initially tracked independent standing balance with him. And he got up to 17 minutes within 2 weeks. And I was like, we don't need to track this anymore. So started doing the 2-minute and 10-meter instead.
All right, any final questions or comments before we wrap up? I guess a thank you to everyone for all of the good presentations, the good conversation. One last call for final questions or comments for our presenters or the group. I think, is the Columbia group raising its hand? I see hands raised at the table.
So we had one more question. Everyone did excellent. We were just wondering, was there any consideration for a HKAFO versus the ischial weight bearing KFO, and why you chose the ischial weight bearing KAFO?
So more of it was just where they needed that support. So initially with my first that standing progression I show, he really didn't need any more support up above the hip, really just needed that ischial support underneath. So I was trying to really optimize how much lateral trunk movement he could use to help him with facilitated stepping, and just giving him that freedom of trunk movement, whereas bracing higher, it would take away some of that. And then there, in a different webinar that I worked on with Kristen, there are some kids that have previously used RGOs as well, but those are just a lot more cumbersome for families to put on, and they're heavier. So to brace as minimally as you need was my goal. And both of them worked very well and functionally just with that support underneath the ischium.
I'd also say that way back in the 80s, it was in the 80s, I know, I remember this. So there was an Italian group, I can't remember whose group it was, that published a very small study on ischial weight bearing CAFOs. And that's how our site kind of initially years ago got interested in it, because they based it on hands-free sitting. And we had orthotists that have really been, I think, even 2 different orthotists over time have been very supportive of the process. So I think that's the key also, is you have to have an excellent therapist that's going to work with the kid, but you also have to have a good orthotist, because there are, like Krista said, there's some subtle sort of little things that you have to play around with in the beginning.
All right, well, we are right at time for our wrap up now. And as I mentioned, we have an invitation for everyone that's online. So Jean, Jackie, Elizabeth, I'll go ahead and put the slide that you've shared just up on screen for everyone and turn things over to you to share more about Step In before we close. And just again, thank you to everybody. We appreciate you being here. So please hold on for just a couple more minutes. You'll have an interesting opportunity presented to you, and then we'll also follow up via email with the abstract booklet, more information on what we're about to discuss, and a recap of programming as well for you.
Thank you so much. We're really grateful for the opportunity to just briefly mention that we're actively recruiting for participants of our study on the development of a proposed supervision scale. So as Sally mentioned briefly before, and Dr. Montez presented yesterday, we're looking at developing a new supervision scale that's proposed that will discriminate between learners and ideally improve reliability. So we're recruiting all SMA physical therapists who supervise or mentor other physical therapists who are new to SMA. And if you commence the supervision from now until the end of 2021, you'd be suitable. So we hope that some of you may have already received an email regarding this study and may be willing to participate. But if you are interested or you have any questions about it, it would be really great if you could email me. I'm going to send my email in the chat so that you don't have to write it down. But as Elsie mentioned as well, we're hoping to send around an email later on after this week concludes to hopefully get some of you involved.
All right, and I'd mention as well, Elizabeth, I think this is okay with you, that should you know others that may be interested in this, please do feel free to pass that email on. So we'll be sending a couple emails. Everyone who attended this session will get an email invitation. We'll also have a broader e-blast that goes out to our clinical trial readiness program participants. I know those include a number of people who've been part of our programming here and in this particular meeting, but others as well. So please do feel free to forward that along. And just by way of closing, thank you again to everyone for being here today. I know that particularly if you've been at conference this week for QASA, it's been probably a lot of video, and we're just so grateful in the context of that everybody was here, that we had so many cameras on, that we had so much good participation and discussion. And then a particular thank you as well to Sally and Kristen for thinking through the program outline and everybody else who's been a part of our programming over time. So thank you very much. We appreciate your participation. We will have, as you've seen, this is being recorded. So we'll have a recording of this that becomes available on our website. We will, of course, check in with our presenters to make sure that all of the recorded material is okay to post. We won't post anything that is not. We're particularly sensitive, for example, to any images of patients and that sort of thing. So you'll get a separate email if you were a presenter today just to confirm that there's nothing that cannot be shared. And then if you know, again, people who'd be interested in viewing this subsequently, please, once you get that link to the video, feel free to pass it along to everyone. So thank you so much, everyone. Appreciate the time, and please do take care.